and welcome to the ASCO Guidelines Podcast, one of ASCO's podcasts delivering timely information to keep you up to date on the latest changes, challenges, and advances in oncology. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Michael Reff from the Network of Collaborative Oncology Development and Advancement, and Dr. Louise Raez from Memorial Cancer Institute in Florida Atlantic University, co-chairs on Medically Integrated Dispensing Pharmacy, American Society of Clinical Oncology, Network of Collaborative Oncology Development and Advancement Association Standards Update. Thank you for being here, Michael and Dr. Raez.
Thanks for inviting us.
Thank you for having us.
Then before we discuss these standards, I'd like to note that ASCO takes great care in the development of its standards and ensuring that the ASCO conflict of interest policy is followed for each guidance product. The disclosures of potential conflicts of interest for the expert panel, including Michael and Dr. Louise Raez, who have joined us here today, are available online with the publication of the standards in JCO Oncology Practice, which is linked in the show notes. So then to dive into the content here, Michael, I'd like to start with what prompted an update to these ASCO-NCODA standards, and what is the scope of this update?
Thank you, Brittany. What led NCODA and ASCO to endeavor in this? And it started back in 2019 as the amount of oral anti-cancer medications became more and more prevalent in cancer treatment. We saw the need providing a blueprint for excellence in care for patients prescribed oral anti-cancer medications, specifically in the outpatient setting. And the update was driven by the rapid growth of these oral oncolytics, starting back in the mid to late 2015 through 2019 or so, and then continued on into the 2020s where we are today. We saw the increase in the complexity of the management of these patients with these therapies, basically outside the traditional clinical settings. And we wanted to make sure that with more cancer treatments that are taken at home than just at the clinic, like in the oral setting, new challenges had emerged around patient safety, access, adherence, and overall treatment success. The updates now address patient-centered and operational interventions designed to improve access, safety, quality, accountability, and outcomes of oral anti-cancer and other supportive care medications prescribed for the cancer patient.
As Mike said, these guidelines help improve patient care tremendously, but also help us a lot as oncologists, community oncologists, that now that we have opportunity to dispense these oral oncolytics, we need help to create our medical integrated pharmacies, and NCODA is providing here a way that how do this safely, efficaciously, good quality. So that's why I think we always do everything for the patients, but also this helps a lot to the doctors, and there are a lot of what we call specialty pharmacies or medical integrated pharmacies now nationwide.
I'll build on what Dr. Reyes had mentioned. This is the impetus. If you looked at the innovation that was coming from the pharmaceutical companies, many of it coming in the oral form for anti-cancer medications. And based on that, taking a look at the infrastructure that is in place in these practices, whether it's in the community or the IDN or health system settings, this amount of innovation that was coming needed to be addressed by taking a look at the medically integrated oncology team. And these standards address not just the pharmacy component, but also the whole continuum of care, starting with a medical oncologist or the hematologist, with the pharmacists, nurses, the pharmacy technicians, others that are involved in the care of the patient. And there were no standards involved in when we approached ASCO back in 2018 to eventually publish the first version of these standards. The need was identified, and we worked collaboratively with ASCO to create the first set and then the revisions, as we talked about. One thing to note regarding the revision plus the original standards, we had a cross-section of the care team on the committee, and we did that very purposefully. So the ASCO-NCODA team curated a committee to help develop these original standards and the revision of these standards with medical oncologists, both from community and health systems, pharmacists from both community and health systems, and also nurses. And we also included a patient that currently has and currently receives oral anti-cancer medication. And so NCODA and ASCO are very proud of the committee that we put together because of the experts in their field, but also extended the invitation to a current patient. And we embedded everybody's expertise in the curation of these standards.
Absolutely. I appreciate that background and context and how it's critical to improve patient care. And these standards really help oncologists. And we're looking across the continuum of care to provide optimal care for our patients. So then next, Dr. Raez, I'd like to review the key points of the revised standards for our listeners. So for Domain 1, what are the key patient-centered quality standards on health equity and social determinants of health, drug access, patient safety, education, and adherence to maximize treatment outcomes?
Yeah, this was a great effort, the multidisciplinary team. And as you can read in the stand, there were more than 240 publications reviewed, more than 55 of them are quoted here. And the standards are in two groups, as you said. With the group one, I'll briefly mention some of them. For example, SDOH, social determinants of health, is very important because as doctors, we prescribe, and sometimes patients don't get the medication, and we prescribe assuming that 100% of the patients will get the medication. But something simple like the patient doesn't have insurance, the patient is underinsured. I have a patient that we didn't have an address to send the medication because he's homeless. Something that as a doctor, you say, oh my God, this is outside my realm, but it's not outside reality. So that's why even if we don't think that this is part of our expertise dealing with social determinants of health, the fact that the patients have food insecurity, they don't have transportation, they don't have insurance, they don't have a caregiver, impact tremendously in the outcomes of the therapy. So that's why basically in this standard, we want to call attention that SDOH, social determinants of health, needs to be identified. There is in the literature countless examples of why this is important. For example, in the guidelines, we quote 2 or 3 examples of prostate cancer studies that, for example, we quote a study of 27,000 people with prostate cancer that were taking oral oncolytics. How come the fact that the elderly, seniors, the fact that they have high prescription costs, and how all of this affected the adherence to the medication. And that's why it's important to identify the SDOH, and in other sections of the guidelines, we said how to address them. No? Another important thing in this domain is the cultural. We need to be cultural sensitive and to take care of all of these social factors. For example, like here in South Florida, we deal with a Haitian culture, Filipino culture, Latin culture, and American culture, and it's a blend, but it's not easy to go from one to the other. Another one is the fact that we have to include new technologies. A lot of patients, for example, we use EMR Epic, and now Epic has everything in the phone. The fact that we can have now, the patient can see his prescription medication over the phone, the fact that can use the phone to request you a refill, and from your phone, you send the refill to the pharmacy, and you notify from your phone to the patient that the refill is sent, and the patient can check in his phone that the refill is ready. These things are amazing because that's why it's important that we incorporate these technologies to the patient care, and in this specific case of dispensation of oral therapies. No? Another crucial point is education. You cannot be sending a patient a package of 300 pills without education. So that's why in our guidelines, mainly clinical pharmacies, or in some centers like mine, we have advanced practice providers. It's mandatory in our centers to have like a 1 hour of education before you send the prescription. So the patient is aware about side effects and contraindications, all of these things. They provide them also materials and also consent. In the old times, you don't give chemo without a consent. Now a lot of people say, oh, it's only a pill. There is a lot of benefits or side effects that can come from the pill. So you need to consent everybody, So another aspect is adherence. I already told about that, but we need to provide patients with a baseline assessment, So you cannot send again the prescription and hope, I'll figure it out what happened in next month when the patient comes back. I tell you, the patient is homeless. Where are you going to send? If the patient is telling you, I don't have insurance, what good is for you to send a prescription? The patient will not get it. So that's why you need to do a baseline assessment of adherence. You need to do a calendar. You need to do electronic support, I mentioned already, with the EMR and the phones. For example, my MIP, my specialty pharmacist, sends me a message in the EMR Dr. Raez, the insurance is not covering, the patient has a high copayment, we are going to delay the dispensation of the medication. So there needs to be a communication. Or sometimes there is a confusion with insurance, and I cannot wait for the poor patient to call 3-4 weeks later, oh, I didn't get the medication, to know what happened. No, my MIP is very good. They send the clinical pharmacist a message, hey, the insurance doesn't believe that the pill is adequate, or you need to provide more documentation. You need to prove the mutation, the genetic aberration, so that if you provide us that, the insurance may approve. So that communication with the doctor is very important to improve adherence. And one important thing that we have in this one that we didn't have in the anterior is the tracking outside medications. A lot of times you say, okay, the insurance allows us to provide the medication. It's 100% responsible. But then the insurance says, oh, no, don't worry. CVS will provide the medication. Entonces, it's not my responsibility. CVS will provide the medication. They have to take care. But we know that outside our specialty pharmacies of MIPs, the care is not very good. So that's why we are taking our ownership that, okay, the insurance said the patient will get the medication from some outside pharmacy, but our clinical pharmacists track that. What happened? Did the patient get it? The patient didn't get it. The copayment is still high. So even if you get the medication from somewhere else, if the copayment is high, we, our clinical pharmacists, help the patient to navigate and get the foundation or the copayment, or finally the maker, the industry partner provides the drug for free, but somebody needs to do the paperwork. And that's why this is very important. We cannot abroad our responsibility because, the insurance said somebody else will give it. I work for the public healthcare system, so my patients, some of them don't have insurance, they are underinsured, so we see these problems every day. And finally, the standards talk about the importance of safety, documentation, verification, monitoring, refills. You need to keep track of refills. We already mentioned how important is the technology to facilitate the refills and the quality.
Yes, thank you for touching on those highlights for Domain 1. It's important that all patients have access to care and these oral anti-cancer medications, and not only just access to care, but safe and effective care. It's really important, as you mentioned, Dr. Raez, to meet patients where they're at or incorporate technology. And also want to note the coordination with external pharmacies that you mentioned and tracking outside medications as well. It's not only important for multidisciplinary care within the oncology practice itself, but also external to the oncology practice. That's why we put together this multidisciplinary panel to develop these standards. So then expanding on that, Dr. Raez, for Domain 2, what are the key operational quality standards? Those on logistics, care coordination, and waste prevention.
Yeah, we have a lot of standards here, but maybe we can summarize in 5 or 6 points. For example, financial toxicity in cost and waste are very important because the patients, you put them on therapy, but as you can understand, if there is disease progression, the patient don't need the medications. And sometimes you get refills even if the patient has disease progression. If you do a dose reduction, the same problem, or you discontinue medication and the patient keeps getting the drug. So you're talking about drugs that are between $20,000 and $30,000 per month. It's a lot of money. There are studies that were quoting in the standards that the waste could be from $1,000 to $3,000 or $4,000 per patient. Another aspect is dispensing. When you dispense a medication, this is not as easy as I'll ship to your house a bag of medications. There needs to be a diagram, a decision tree. You need to train the staff to know what we're doing. There needs to be an auditing of the process. They need to be even packaging and shipping. For example, I'm in Florida today, and outside in summer it's going to be 95 degrees. Because everybody leaves the package outside your house, and sometimes you go the whole day until when you come at 6 p.m. There are medications that you cannot be left outside there, I don't know, it sounds like a joke, but I have a patient that the medication used to be stolen because people thought that was something important, and of course it's important because it's a $20,000 medication. So the poor patient, because he lives in an area that is not safe, has to come and pick up in person. All of these things sound very trivial, but that's real life that affects adherence. Another important thing is shortage. This is something that we just suffered 2 or 3 years ago, and we have to think about what happened in the next shortage. What happened if there's going to be a shortage? What we do or how we're going to do that. Now we know it's something that is happening probably very soon again, and something that we have to consider. Another standard is the care coordination. You need to have probably, if it's possible, a coordinator. I know that for small practices it's very hard, but for big cancer centers, you should have a coordinator of this. We already mentioned before the communication between the physicians and the doctors to coordinate the care. You need to write the prescription again. You need to provide more information or to be notified, hey, the patient is throwing up in the first week. You need to see the patient, please. So this type of communication needs to exist so we can serve the patient better. It's also important, we're improving quality and we're improving care. It's important to try to collect patient-reported outcomes. It's something that now we have the opportunity, if we do things well, to do it and show that we're providing a better care. The other thing is that we already mentioned SDOH in the other standard. In this standard, we mentioned mainly SDOH to partner. For example, we collect in my center SDOH, and I always get frustrated when the patient doesn't have transportation. But I didn't know that there are local institutions that provide free Uber rides, free Lyft rides. So that's why it's important to partner with these institutions. I have a local grocery chain that provides free food for the patients, and I didn't know that. It's important to be aware what the patient needs and what resources do you have to fulfill the SDOH. That's the part that we mentioned in here. So that's why, in summary, the 6 probably most important points here. I'll ask Mike for some comments.
Thank you, Dr. Raez. Brittany, to answer your question, and as was pointed out on logistics, care coordination, and prevention of waste, certainly that is an aspect that has changed in the revision that we're here to talk about. There's really 2 components to waste, and it's cost avoidance and then waste prevention. And as Dr. Raez mentioned several times, the importance of the medically integrated team and having the ability for that practice to fill that prescription internally and have robust documentation. Cost avoidance is a critical component that the medically integrated pharmacy or the MIP can help the total cost of care. And that is by preventing errant fills or waste that can occur by intervening in the care of the cancer patient, as we do every day. But when the practice has access to the medication and can fill that prescription in-house in the medically integrated pharmacy, that team, that care coordination that takes place can prevent those errant fills or additional fills when there's dose reductions, there's holidays, there's things that happen in real time. And it's impossible for a mail order pharmacy that's in another state that has lead times when a prescription needs to be mailed 7 days or 10 days before the patient will run out of the medication. It's impossible for them to logistically coordinate that care like we can internally within the medical integrated pharmacy. So we prevent waste and overall cost of care by cost avoidance and having that coordination or that continuity of care that we talk about. And we prevent waste from the mail order pharmacies by taking that prescription internally and filling it, but also doing it in a way that's more sustainable and cost effective for all stakeholders in the oncology ecosystem.
Absolutely. Thank you both for reviewing those key standards for Domain 2 and touching on the importance of distribution logistics and all the things that a medically integrated pharmacy needs to think through in getting oral anti-cancer agents to patients. Following that, Michael, we've touched on this a little bit earlier, but how will these updated standards impact clinicians and oncology practices?
Yes, and as Dr. Raez and I have discussed throughout this podcast, these additional standards are there to help support that continuity of care by educating the clinicians that are in the oral anti-cancer medication space to elevate their provision for these oral therapies. What I mean by that is the practice has to perform at a certain level in order for them to, as I call it, deserve the right to fill that prescription by having the processes and procedures in place. And these standards, these updated or revised standards, is the blueprint for better patient care and to help the practices execute on that journey of continuous improvement.
Yeah, I only want to add, we have practical examples in the guidelines. We quote a couple of studies that have been successful. And this year, for example, I am a lung cancer doctor. We are presenting in World Lung our standards of adherence to oral oncolytics for EGFR therapy, following the NCODA ASCO standards, we're around 95% of adherence. We are a healthcare system that is public. We have people with no insurance and a lot of social determinants of health. We are trying to show that it's feasible, even in the most difficult circumstance, when you follow the standards, to be successful.
Definitely, these standards can help clinicians and oncology practices succeed in providing these medications. So then beyond that, and to wrap us up, Michael, what do these revised standards mean for patients who are receiving oral anti-cancer medications?
Yes, great point and question, Brittany, because we have covered the benefits to the clinicians and the practices themselves, but how is this going to support better patient care? And it does it in a whole host of ways. I'll cover just a few of them. What I'm about to share with you relates back to what we call at NCODA the core claims. Like, what's the core claims of having a medically integrated pharmacy within the practice? And there are 7 different core claims that we feel practices that are focused on the continuity of care can deliver better outcomes that are embedded in these standards. And it's talking about abandonment, adherence, access and affordability, speed to therapy or time to fill, as we call it, education, patient satisfaction, and cost avoidance that we covered earlier. So those are the core claims that a practice that follows these revised standards can help elevate. So faster and more affordable access to the oral cancer medications, individualized support to address barriers like transportation, finance, language, or health literacy, and so on. Clear, patient-friendly education, something that is near and dear to all clinicians' hearts, and of course the patient that was on our panel or on our committee, to empower them to manage side effects and recognize when to seek help. And a stronger partnership with a care team, with regular follow-ups focused on their experience, challenges, and successes, and then greater overall safety to proactive monitoring for medication errors or complications. So all of these aspects, or tenets, as I'll call them, are baked into these quality standards that are totally aligned with NCODA's core claims document that, again, talks about abandonment, adherence, access and affordability, speed of therapy, education, satisfaction for the patients, and also cost avoidance.
I only want to add and invite the community to adhere to these standards, to practice the standards. You will be providing the best patient care that we can nowadays.
Definitely. I think these standards are very important. And Michael, I thank you for touching on those key claims from NCODA. I think those, along with these updated standards, will improve outcomes for patients everywhere. So I want to thank you both so much for your work to update these standards and all the time you put into it. And thank you for your time today too, Michael and Dr. Raez.
I'd like to thank not only the committee, my esteemed committee that helped support the standards and the revision, many of the original healthcare providers and patients that were on the first go of the standards were part of the second standards. We revised it, of course, and we got additional support from the new committee. And certainly ASCO and their partnership and collaboration with NCODA has been tremendous. And we look forward to the oncology community at large adopting these standards. Again, to work together, we do become stronger, and it will improve cancer care for patients receiving oral anti-cancer medications. So thank you, Brittany.
I only want to say the same thing. Actually, there is probably more people in NCODA that is not in the publication that has helped. Same in ASCO. So we want to give thanks to Dr. Stephen Grubbs, our leader in quality. He's retiring. We're going to miss him, but he has been a key collaborator with Mike, organizing these standards for the last 5 or 6 years. So looking forward to these standards in practice.
Absolutely. A big thank you to the entire panel and everyone who contributed to this, and NCODA as well. And then finally, thank you to all of our listeners for tuning in to the ASCO Guidelines podcast. To read the complete standards, go to www.asco.org/standards. I also encourage you to check out the companion episode on these standards on the PQI podcast by NCODA, which you can find on Apple Podcasts and Spotify. You can also find many of our standards and interactive resources in the free ASCO Guidelines app, which is available in the Apple App Store or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.